Good morning, everyone, and welcome to the 13th episode of the Medical Education Clinical Reasoning Program. We hope that you've had a peaceful weekend and that you're finding our program to be beneficial and enjoyable. Let us start this special episode by welcoming today's panelists. Our clinical advisor for today is Dr. Fahad Sindi. Today's resident is Dr. Sarah. And for the first time, we are pleased to welcome our guest discussants from outside UAE University's College of Medicine and Health Sciences, Khadija Mohammed and Yumna Ayman. Let's give our panelists a chance to briefly introduce themselves, and then we'll give the mic to Dr. Sarah to walk us through today's case. We can start with you, Dr. Fahad.
Good morning, everybody, and welcome on a very nice Saturday, filled with education and joy. I'm one of the consultant heart failure and transplant cardiologists at Cleveland Clinic, and I welcome everybody.
Dr. Sarah, can you please introduce yourself, and then our speakers, Khadija and Yumna.
Hi, good morning, everyone. My name is Sarah Al-Qasimi, and I'm a internal medicine R1 at Cleveland Clinic, Abu Dhabi.
Khadija, can you please introduce yourself?
Assalamu alaikum. Good morning, everyone. I am Khadija Mohammed. I'm an intern now doing my internship in Sudan.
And Yumna, please introduce yourself.
Good morning, everyone. I'm Yumna Ayman. I'm a fourth-year medical student in Ras Al Khaimah Medical and Health Sciences University.
Okay, thank you all for this introduction. Dr. Sarah, the floor is yours.
All right. Before I start presenting my case, I'd just like to put down two very important ground rules since we have discussants from outside of UAEU for the first time. There are two main things. One is that I don't know is a very valid answer here because we're all here to learn, and you not knowing something is very okay. And the second thing is that it's not important to get the diagnosis right. But what is important is that we want to know the way that you think through a problem and how to better organize your way in thinking a problem. So those are the two things that I'd just like to highlight on before I start. All right, so let's begin our case. We have a patient who's coming into the ER. He is a previously healthy 21-year-old male who's presenting with abdominal pain for the past 7 days. Khadija or Yumna, who'd ever like to start, how would you approach this case? I'd like you to tell me how you think about it. Walk us through it.
I would start off by going in the Socrates order. So I will start asking him about the site of the pain and the onset and character, radiation, associated symptoms, timing, and exacerbating symptoms and severity.
Okay, that's an excellent way to start. So he reports that this abdominal pain started suddenly. It's located on the periumbilical region and it does not radiate anywhere else. The pain is intermittent, it comes and goes. It's described as sharp. He doesn't notice anything that makes it better, doesn't notice anything that makes it worse. He's tried some painkillers, but they haven't helped. Um, and he came to the ER because it's more intense and more frequent now. What else would you like to ask?
What about the associated symptom? If there was vomiting, fever?
So, no vomiting, no fever. What else would you like to ask? Associated symptoms wise.
Bowel habits, diarrhea or constipation?
Khadija, is there anything that you'd like to ask? You can go through a full review of systems. We'll see if anything pops up in that. If there are no questions, then I will go through the review of systems myself. So yes, I'm not sure if Khadija was trying to say something, but we can't hear you.
Uh, hello.
Yes.
Ask about
It seems that Khadija is facing some Wi-Fi issues. We'll just check with her.
yeah. Okay, now it's clear. Sorry.
No worries. So you wanted to ask something?
Yeah, loss of appetite. If he has loss of appetite.
He's been having nauseas, and that's the reason why he has been
Mm,
hasn't been eating well.
okay.
Guys, this is Dr. Fahad. I don't know if you can see the meeting comments or chats.
We can see it, doctor.
So what do you guys think? Yeah, I mean, I don't want to take a long time with this, but obviously my question might not be directly related to medicine, but again, one of the very close subjects to medicine, which is physics. Now, with the atom model, obviously you have a central nucleus, which is followed by electrons. So those electrons are actually symptoms that the patient present with. But you guys remember that the electrons don't all rotate on one orbit, they have multiple orbits. Yeah, I forgot to tell you that. You guys, you're in a safe place. So as Dr. Sarah said, you're welcome to say anything. Now, obviously, I give this, collateral example just to emphasize a very important concept that in abdominal pain, also with other, disease presentations, it's very important to get the inner shell of the electron first before going to the outer shell. And what happens is that for you to get closer to the inner shell, that requires a lot of energy. And other very important associated features that are very important can be added on once you know exactly the core of this abdominal pain that we have. So if I kind of want to take a step back and just give you my humble approach about abdominal pain, is that I think about abdominal pain in one of two important symptoms. I did hear Socrates, which is a good way, but my two main diagnostic thought processes, which are very close to the shell, are where is the pain, the site of the pain, and what does it feel like? And these are very important initial questions. So if we reset back to the discussants, what are different areas of the abdomen that have different structures that can cause pain? That's an important question.
The right lower quadrant.
Sorry, how many coordinates are they? I mean, coordinates, there are four, but there are actually 9 regions of the
9.
abdomen. They're like the XO game. Anybody play
Good.
the XO game?
9 regions. We have
Yeah.
right hypochondrium, epigastric area or region, left hypochondrium, and then we have the periumbilical area, right iliac fossa and left iliac fossa in the pubic area and the flanks.
Okay, that's good. So you've outlined the 9 areas. Now, obviously, our tutorial is not going to be talking about all the 9 areas today, but we're going to focus, as Dr. Sarah is focusing, on the pain itself.
Okay.
So, deciding where Dr. Sarah told you where the pain is, what are structures that are there in the periumbilical region?
The small intestine.
Excellent. Anything else? So the other important question, once you localize one or two important organs that lie behind that area, you want to think about the type of pain. And this is a key opening statement for the whole tutorial. There are only two types of pain in the abdomen. The patients can describe different subjective pains, but there are either a dull, sharp, aching pain that is there that's there all the time, or there is what's called colicky pain, which comes in bouts. Now, why is this distinction early on very important? Sarah, you want to elaborate?
So I think that dull, sharp pains are usually pains in more visceral organs, whereas the colicky kind of pain are pains where you have organs that are able to contract and close and be stimulated, basically.
This is the best explanation I've ever heard. Sarah is immediately on the money. This distinction is so important because if it's a pain that comes with bouts where, let's say, it's a small bowel, or let's say is the ureter, or anything that has stratified smooth muscle, then that's not going to be the liver, nor it will be the stomach. So again, location, description helps identify those classical regional pains right off the bat. Okay, and then you can go through your onset, periodicity, duration, radiation, all of this that we talked about, and then be very cognizant that when you have pain, a lot of the organs in the abdomen have been derived embryologically from three main sources: the foregut, the midgut, and the hindgut. Now, we're not going to go into the details of this, but remember, they also derive their blood supply and they pull the nerves with them. So beware of pain that initially is presented because of dermatomal distribution, meaning irritation of the visceral peritoneum, where the pathology develops into irritation of the parietal peritoneum that localizes. Okay, so I just want you to kind of, anytime from this day forth, you have an abdominal pain, ask yourself which quadrant it is, what are the structures behind it, what is the description of pain, and try to close your eyes and imagine what organ is being the culprit. And then you can build on, like the atom, other symptoms that will either prove the diagnosis or disprove it. All right, so we'll let Sarah continue.
All right. So if there are no other questions regarding the HPI, I'm just going to continue the last part. Yumna, Khadija, do you have any other questions?
No, thank you, doctor.
No,
Okay. Um, so the other associated symptoms that were not asked in this case was that he does endorse myalgias for the past week as well, and he has dark urine. And when you talk to the patient, you see him, he's very anxious regarding this pain. Um, and his brother, who brought him in, also tells you that he's been very, very scared and anxious. He's never seen him this scared before uh, in his life. And the brother also tells you that the patient had went on a party around 2 weeks ago and took a very large amount of beer. All right.
okay.
For the ROS in this case, he denies chest pain, no cough, no numbness, no weakness, no vomiting, diarrhea as mentioned, no rashes, no dysuria. So, at this point of the history, what are you thinking about basically, or how do you think about it? Like, walk us through what is your thought process regarding this kind of presentation with these kinds of symptoms. Either one of you can start. It's fine.
Possibly, maybe obstructive jaundice
Okay, and why do you say that?
because of the dark urine
Mm-hmm.
and the drinking habit.
Okay. Is that your top differential at the moment?
My
I'm also thinking of small bowel obstruction, maybe.
Okay, and why do you say that? Again, when you bring up a diagnosis, tell us what supports it, what doesn't fit in it. Just give us how we are thinking about it exactly.
Because it's a peri-umbilical type of pain, but there's no vomiting, and so maybe it's not small bowel obstruction.
Okay, that's still a differential that you can put on. Anything else? Khadija, if there's anything you'd like to add?
uh, could it be appendicitis because of the periumbilical pain?
Yeah, yeah, definitely could. Early appendicitis does start on the periumbilical region.
Could it be traumatic?
Um, there is no history of trauma endorsed.
But since he was drinking and there's dark urine,
Mm. That's fair too. Maybe he didn't know that he had a trauma sustained to him, and his brother didn't know as well. That's possible. Certainly on there on the list.
I think I can make a bit of that association, and especially if somebody who kind of drinks in excess and find themselves on the kitchen floor in the morning, beware of bruises on the thighs or the legs because of immobility. And those patients can present with, acute rhabdomyolysis, and the dark urine is probably muscle in the urine because of prolonged immobility. So that is a possibility as well. Um, remotely to that, a gallstone ileus also can present with periumbilical pain. That's a bit rare. But yeah, associating this symptom with the dark urine becomes key in the diagnosis.
Yes, definitely. The dark urine is something very important in this case. Any other differentials? Um, so abdominal pain is a fairly simple but also a fairly intimidating chief concern to have a patient present with because there are so many things that can be going on in a patient that presents with abdominal pain. So it's very important to have a framework to guide you, and Dr. Fahed already alluded to this earlier on with having an anatomical approach with the abdominal organs. So let's take it a step further. Let's take a multi tier approach for abdominal pain. We've already spoken about the 9 quadrants and what organs can be implicated in that case. But let's think of another kind of framework. What are the things that can be life threatening in a patient and presents with an abdominal pain? Emergencies should always be ruled out, like no matter how your patient presents. You have to rule out the things that can kill a patient immediately. So, what are the life threatening things that you can think of that presents as an abdominal pain?
peritonitis,
Yes, correct. So, any kind of perforation in the GI tract can cause peritonitis, very fatal, and has to be ruled out immediately. What else?
Perforated viscous.
Yep, yep. Perforation under peritonitis as well. Same kind of family. What about vascular things? What vascular emergencies can present as an abdominal pain?
Acute mesenteric ischemia.
Yes, excellent. Yes.
Aneurysms?
Abdominal aneurysms, if it ruptures, yes. Or what about a patient who is a female comes in with an abdominal pain?
Ovarian cysts, maybe?
Um, cysts aren't usually fatal, but there's something else that you should think of in a patient who comes to the ER. This is something that all ER physicians do. Any female who comes in with an abdominal pain, have this ruled out.
Ectopic pregnancy?
Yes, correct. Ectopic pregnancies. And one more thing is obstruction, which I think one of you had already mentioned during the HPI. Obstruction, specifically small bowel obstructions, are something that can be fatal as well. Okay, so those are things that should be ruled out from the beginning. And they're usually very quick to rule out on exam and the presentation of the patient as well. But we're not going to go through that all because that's going to take a few time. So we went through the abdominal organs and what can cause abdominal pain. How about we take it another step and think about extra abdominal organs that can cause abdominal pain? What can you think of that is not an abdominal organ that can cause abdominal pain? Yes, correct. Excellent. That is an excellent one. So under cardiovascular, under pulmonary, MI, what else?
So just to kind of comment on MI, that's a very important diagnosis that sometimes is missed, especially when patients present with epigastric pain. And doing an ECG is essential on all patients suspected. But do you guys know why MI presents with abdominal pain or epigastric pain?
Is it because of referred pain?
Excellent, excellent. It is referred pain, but how?
Is this an embryology question, Dr. Pat?
No, it's just the way the infarction is. Usually the inferior wall of the left ventricle actually lies on the diaphragm. And mostly if it's an inferior wall MI, irritation of the diaphragm causes refer pain to the epigastric region. So that's something kind of, just to keep in mind. It doesn't mean it's an inferior MI, but importantly, inferior MI can cause abdominal pain.
Oh, interesting. I did not know that. Thank you for that addition, Dr. Fad. So other than an MI, what else under cardiovascular or pulmonary that you can think of can cause an abdominal pain? Lungs, if we think of lungs.
Right or left lobar pneumonia?
Lower lobe pneumonias, basically. Yes, correct.
Lower lobe, yeah.
Okay. If we move out of the thorax and we go to the pelvis, what are things that can cause abdominal pain in the pelvis? In a male, in a female?
Endometriosis?
Yes, that's a good one, yeah. What else? In regards to males and females, what can happen? Ovarian torsion or ruptured cysts, like was mentioned before. Cancers as well can cause abdominal pain. Can you think of renal causes of abdominal pain?
Renal stones.
Renal.
Yes, correct. Renal stones. Pyelonephritis as well can present as abdominal pain. Okay, now we've gone through the life-threatening causes of abdominal pain. Then we went to the anatomical approach and what abdominal organs can cause abdominal pain. Then we went out of the abdomen to think of the extra abdominal organs. Now, if we have a non-organ cause of abdominal pain, can you think of anything? And I'll give you a hint, metabolic causes. I think Khadija is trying to say something, but she seems to be having Wi-Fi issues again.
Diabetic ketoacidosis.
Yes, correct. That is a very important one.
Again,
Yes.
excellent diagnosis, but why does diabetic ketoacidosis cause abdominal pain?
Is it because of the ketones? Maybe.
You're absolutely right. But what do the ketones actually do?
I'm not sure, doctor.
All right. No, no, I like this answer because it's interesting. I mean, you see sometimes patients presenting with an acute abdomen, very fast respiratory rate, young patient. So two things. One, the keto acids, as you said, they're acidic, so they irritate the stomach. And that's also the pathophysiology of actually vomiting. And that's also key in the pathophysiology of DKA because it causes further volume loss because of vomiting, more insulin resistance, increase in blood sugar. So the perpetual cycle of DKA is fueled by you losing a lot of volume from vomiting, but also it delays gastric emptying, and patients develop some gastric distension. And one of the things initially when you're treating patients with DKA is to put an NG tube, is to relieve that distension and and vomiting.
Okay. Is there any electrolyte disturbances that can cause abdominal pain?
Hypocalcemia.
Hyperkalemia.
Hi, I'm sorry, can you repeat that one? You both said different electrolytes at the same time, so
I said hyperkalemia. She said
Hy-
hypercalcemia.
hyperkalemia, yes. I mean hypercalcemia, sorry. Yeah, hyperkalemia, calcemia can cause abdominal pain. There's a mnemonic for hypercalcemia that everyone has probably heard before that I can't recall at the moment, but One of them was aches, groans, something like that. Anyway, abdominal pain is one of them. Yes, correct. If you have a patient with kidney failure and they present with abdominal pain, fatigue, what would you think of? Or they
Dehydration.
Uremia.
uremia, yes, correct. Dehydration is part of that, yes, but it's uremia specifically that causes it. Again,
Yeah.
it's a buildup of toxins in the body that causes abdominal pain.
Yeah.
Sorry, Dr.
And
Khan.
yeah, again, I agree with Sarah. Buildup of toxins, especially in uremic syndrome, they're very nauseated. They might vomit as well. And the other important thing not to forget, especially with vomiting and patients who continuously retch and vomit, they might develop secondary abdominal pain, where the culprit might be actually intracerebral. So anything that raises intracranial pressure, especially will cause early morning vomiting, especially if it's a chronic process. But if it's an acute process, somebody, let's say, has a procedure, is given heparin or given lytics or something, and they persistently vomit. I had a patient actually in the cath lab following a procedure, and the CT scan showed a bleed. And surprisingly, I'm going to put it in a question and then I'll answer it. It was mostly in the posterior fossa because it allowed bleed to accumulate longer. But things to think about. But that's a great differential.
Okay. Is there any other metabolic cause that you can think of abdominal pain? Before I move on to medications and toxins that can cause abdominal pain.
Could it be an adrenal cause?
Yes, yes, that's true. I did not think of that. Adrenal insufficiency can cause abdominal pain. Yeah, that's a good one. All right. Anything else for metabolic wise? Before we move on to medications.
Storage
Top.
diseases.
Storage diseases. Yeah, that's an excellent one as well. It's not something that we see very often, but it is definitely something to consider. Anything else?
No, doctor.
All right. So medications or exogenous toxins that can cause abdominal pains. What can you think of? And one of the things we mentioned in this patient's HPI specifically as a toxin.
The alcohol.
Sorry, Khadija, can you repeat that? I didn't hear you.
And this patient, alcohol could
Yes,
be.
alcohol. Correct. Alcohol. Alcoholic ketoacidosis. There's a specific type of metal, if it was ingested, it can also cause abdominal pain. Usually seen in an occupational, um, as an occupational hazard. Again, not something that you see every day.
So before we give the diagnosis, there's a very good episode of Doc Martin. Has anybody seen Doc Martin?
Oh,
It's a medical series. It's very interesting. A surgeon who develops homophobia, so hemophobia. So he's afraid of blood. But again, it's very good because these, series episodes always have a medical theme to them. And the first time I actually learned about this type of poisoning that Sarah is going to talk about was from TV. But it's very interesting because it can be common in certain areas of the world.
Any guesses to what this metal might be? Lead poisoning. I mean, I know it's not very common, but it's
okay.
something. Yeah, but it's something that is still seen day to day. And again, there are places in the world where it's more common than um, around our region.
and the clues look for an old house, recently
Yeah.
painted, abdominal pain, change in behavior. So there's a number of kind of herald of symptoms, but it's a very interesting presentation.
All right. Are there any medications that you can think of can cause abdominal pain? I mean, I personally did not know this until I prepared for this case, so I understand if you can't think of any medications.
Could it be NSAIDs for
NSAIDs,
peptic
yes,
ulcer?
yes, that is an excellent one. Anything else? So the other two medications that I could find were opioid, either overdose or withdrawal can cause abdominal pain, and anticholinergic medications. If anyone has any other additions to medications and toxins, um, we can hear them out. I think Khadija again is trying to answer, but is having Wi-Fi issues. Okay, so now that we went through a framework of how to think around abdominal pain in general, let's go back to our case and try and apply it on our patient here. I know a lot of things aren't related, but right now, after knowing the information that you know, what kind of bucket that this patient's abdominal pain fits into? Is it a life-threatening condition? Is it an extra abdominal organ, an abdominal organ, or even a non-organ cause of abdominal pain? Let's just start with that. Yumna, what do you think?
Yes, doctor, I'm sorry. Could you repeat the question?
So I was just asking, what bucket do you think of abdominal pain cause does this patient's abdominal pain fit into? Is this to you from the HPI alone? Is this a life-threatening cause? Is it an abdominal organ, an extra abdominal organ, or even a non-organ cause? Like, what do you feel at the moment? And it's fine if you don't know.
I feel like it could be related to the alcohol, but
Okay.
I
So
don't
you.
think it's
Mhm.
life-threatening,
Okay.
and doesn't seem like an organ cause. I'm not sure.
Okay. So which one of the four that you would think it fits under mainly? Is it the non-organ cause then, if we're blaming the alcohol?
I think so, yeah.
Okay, all right, that's a fair assessment. Khadija, do you agree with Yumna?
Sorry, but what did he say?
So Yumna thinks that the abdominal pain in this patient is caused by a non-organ cause, which is the alcohol.
Mm.
Do you agree? Do you have another opinion, or would you like to add on to that?
I would add organ cost to it.
Okay, what organ would do you think it's causing abdominal pain?
Uh, gallstone ileus maybe, and appendicitis too.
Okay. Is it because of the location? Can you tell us
Yeah,
why you're
yeah,
thinking that?
because of the location of the abdominal pain.
Okay, sure. Um, Let me just go over the HPI in case I forgot to mention something. Oh, there is one more thing I forgot to mention. There is no relation to food intake, and he can eat his regular meals perfectly fine. Okay.
Okay.
I don't know if that changes anything with either of your thought processes, but that's there. Okay. All right. Let's just complete the rest of the history before we move on to examination. So his past medical history is insignificant. He has not taken medications before. He has no known allergies. Family history is unremarkable as well. For the social history, he is a college student. He takes usually 2 to 3 beers per week. He is a non smoker and does not endorse recreational drug use. Okay? So a fairly non significant past history. Okay, if we move on to the examination now. Vitals, his temperature is 37, heart rate is 92 and regular. His BP is 160/80. His respiratory rate is 16, and he's satting 98% on room air. So this is a question that I like to ask regarding physical exams, but what do you think of the patient through his vital signs? Is this something worrying? Is this something that you can wait on? Something that you can continue the examination and then work up later? Or do you have to act now based on the vital signs? And it's an important question to ask with every patient that you meet.
His vitals seem within normal limits except the BP.
Mm-hmm. Could there be an explanation for the high BP?
Maybe because of the pain.
Yes, that is correct. So any patient who is in pain is going to be hypertensive. And you'd be surprised by how high it can be. I've seen patients in pain
Yeah.
that go up to 190s, 200s just from the pain alone. So yeah, I agree with you both. It's a fairly stable patient who is in pain. Yeah. So when you see him, generally, um, he is he looks ill appearing and he's distressed because of the pain, and he's a little bit flushed and diaphoretic. Okay. Um, his his head, ear, nose, throat exam is all normal. Integumentary, again, I mentioned he's sweating and he's kind of red and flushed. Um, CVS exam is normal, really. Respiratory is normal as well. His GI exam, he has a soft but mildly generalized tenderness, no specific area. There are normal bowel sounds and they are present, and there was no guarding or rebound noted.
I think just kind of a few comments on the exam. There is what's called order of operations in any system, and the abdomen is actually no different than that. So when a patient comes in tachycardic or hypotensive with abdominal pain, a list of things spur into your mind. But key to what Dr. Sarah's alluding to in the abdominal exam is the absence of peritonitis. And again, irrespective of the organ involved, or whether it's an inflammation or a perforation or a twisting, then peritonitis, generalized peritonitis, is the end game. Now, Localized peritonitis occurs mostly because the policeman of the abdomen, the greater omentum, tries to clamp down and locks down the area of inflammation to isolate it from the rest. So those patients are gonna really twinge and have pain in that area. But if the abdomen becomes completely inflamed with generalized peritonitis, you'll have what's called board-like rigidity. So, I mean, these things are important. As Dr. Sarah mentioned, relevant negatives in the case. And yeah, we can continue the exam.
All right. For the neurological examination, he's awake, he's alert, he's oriented. He was just very anxious throughout the examination. Okay. So at this point of the case, has your differentials changed at all? Is there anything you'd like to add based on the examination? And what kind of investigations? Or let's just stick with the differentials for now.
So at this point, we can rule out obstruction and peritonitis.
I definitely agree to the peritonitis, but can you explain how you ruled out obstruction from the exam?
Because he eats normally and his bowel habits are
Oh, yeah,
normal.
the history. Okay, okay. All
And
right.
yeah.
Okay, and what is your top three differentials, just for the sake of time? What are three differentials that you would put on this patient? Again, you guys already mentioned some before. I don't know if you'd like to repeat it now based on what extra information that we have.
Alcoholic ketoacidosis.
Yeah, okay. That's a fair differential.
He could also have the lower lobe pneumonia
Okay, sure.
if he aspirated something.
When he was intoxicated, you mean? Yeah, that's something to consider as well. Okay. Anything else? Khadija, you can type out your answer if you're having issues with the Wi-Fi. Maybe that can be sent. Okay, she seems to still be having some issues. Um, all right, Yumna, is there any other differential that you'd like to add before we move on?
No, doctor, that's it.
Okay, so based on your thinking and what information that you have at the moment, what investigations would you like to order on this patient?
Full CBC
Okay.
and liver function tests
Okay.
and an electrolyte panel
Sure,
and
that's a fair start.
maybe renal function tests too.
Renal function tests because
Of
what
the
are you
dark
thinking?
urine.
Because of uremia and all that.
Okay. I mean, we didn't talk about the urine a lot, so let's just go through that very quickly because it is a very key associated symptom in this patient specifically. So when you have dark urine, to be considered overlapping with abdominal pain, this can either be caused by an endogenous or an exogenous pigment. So when we think of things that the body can make and can discolor urine, we think either heme positive, meaning there is blood in the urine, so hematuria, or it can be heme negative. So the urine could be concentrated, there is elevated direct bilirubin, or there are even things like porphyrias. You guys know what porphyrias are? Have, does this ring a bell? Have you heard of it before?
Yeah, increase in heme level in the body.
Yes, yes, that is correct. Um, and exogenous pigments to consider are foods. There are some foods that can discolor your urine, for example, beets. There are also medications that can change the color of your urine, like
Antituberculosis.
exactly, yeah, it can
Rifaximin.
turn urine orange. So those are just things to consider. Okay, right. So back to the investigations. Um, for the sake of time, I'm just going to go through what investigations were done in this patient. So they had a CBC done, and it showed white blood cells of 17 with a left shift, hemoglobin of 17, platelets were normal 300. He had normal electrolytes, normal liver function tests, so the bilirubin was all normal. Lipase was normal as well. They did a CRP, so and that was normal, so no inflammation. Um, they did a urinalysis because of the dark urine, but that turned out to be normal as well. So the labs were fairly unrevealing, other than a white blood cell of 17. So does this change your differential in any way?
So we have to think of infectious causes.
Infection.
That's correct. That's always something to consider with an elevated white blood cell. But something to consider as well is that white blood cells can be increased in stress induced situations. So, yes, I agree, infections are very important to think of, and they should be the top thing that you think of. But stress can also increase it. Okay? Right. Is there any imaging that you would like to do on this patient?
Abdominal ultrasound.
Okay, yeah. What are you looking for in that?
See the organs, whether if they're inflamed or not.
Okay, is there a specific organ in mind?
Appendix.
Sure.
We could look for free fluid,
Can you explain that more? What
as
do you
in we
mean?
can go for the fast ultrasound and look for free fluid in the abdomen that might be the reason for abdominal pain, since he might not be aware if he went through trauma or something.
Mm, I think I would agree in that setting if it was more of an acute pain. So remember, he's had this pain for the past 7 days now. If
Oh,
he had a traumatic injury, I think it would present earlier. At least that's my opinion of it. Okay, so other than an ultrasound, anything else that you'd like to do?
it could just be muscle pain,
And why do you say that?
because of the generalized tenderness, myalgia, and the dark urine, and seven
So,
days.
so are you're thinking of rhabdomyolysis, Annie?
Yes.
Okay. But
And everything else is normal.
that's true. Okay. So again, just for the sake of time, I'm going to go through the rest of the investigations that they did for this patient. So they didn't do an ultrasound, unfortunately, so I can't result that here. But they did a CT abdomen pelvis with contrast, and it only showed a large stool burden because he has been constipated for the past 5 days, but it was otherwise normal. They admitted this patient because to this point they still weren't sure what was wrong with him. And they did an EGD, an upper endoscopy, on the second day of admission, which was also normal. Um, so they kept him in for monitoring and pain control. And by the fourth day, the anesthesiologist who had um, prepared this patient's EGD um, suggested that how about we check the urine for porphyrins? And they thought it was a good idea. So they sent for a urine porphobilinogen screen, and it was extremely elevated. This was on day 4 of admission. So the final diagnosis in this patient, based on that one test alone, was acute intermittent porphyria. Yumna or Khadija, do you know, what do you think of the final diagnosis? Is there anything that you know about porphyria before that you
Excuse me,
realize?
guys, Sarah and team.
Yeah,
Thanks very much. I'll have to make a go because I need to answer a phone call from the hospital.
sure,
It's been a great pleasure, and we'll see you next week, inshallah.
inshallah.
Okay,
Thank you,
guys.
doctor.
Bye.
Okay, so Khadija or Yumna, is there anything that you know from about porphyria before that makes sense now that we have the diagnosis?
I haven't
No,
heard about it much.
You've never heard about it. Yeah, it's
just
understandable.
heard that it's a part of heme formation, hemoglobin
Yes.
formation.
Yeah. Okay, so we're going to talk now a little bit about porphyrias in general and acute intermittent porphyria specifically. So, as it was mentioned, porphyrias are disorders of heme synthesis. So, each type of porphyria represents a specific defect in the pathway of synthesis, and this can either be inherited or acquired. And acute intermittent porphyria is the most commonly encountered porphyria in clinical practice. It is an autosomal dominant inherited defect that leads to a buildup of two porphyrin precursors, ALA and PBG. And I do not recommend going through the trauma of revising biochemistry again, but if you just go through the pathway and you'd see how these two specifically get built up once their enzymes are deficient. Okay. So the triggers for acute flares of porphyria include really any physiological event that can lead to increased demand for heme production. And these things include prolonged fasting, alcohol use, smoking, hormonal fluctuations like menstrual cycles or pregnancy. There are also some drugs that can increase heme turnover, and so they can also trigger a porphyria attack. The symptoms are caused by the neurotoxicity of the heme precursors, and they usually lead to a wide range of neurological manifestations. So, these include neurovisceral symptoms of abdominal pain, constipation, nausea, vomiting. There's also sympathetic overactivity leading to hypertension, tachycardia, arrhythmias, psychiatric symptoms of anxiety, paranoia, hallucinations, delirium, and in very severe cases, you can see neuropathies that can lead to paralysis of the respiratory or bulbar failure. But those are in very extreme cases. And in our patient, for example, if we link this to our patient, he did have the abdominal pain, he had the constipation, maybe the nausea, and the psychiatric symptom, maybe the anxiety. So I mentioned a lot in both the HPI and the physical exam that he was very anxious. And his brother had mentioned this is the first time he has been this scared in his life. Okay?
Yes.
So the diagnosis is based upon characteristic symptoms and specialized tests. So it should always be suspected in a patient who has an unexplained abdominal pain, repeated episodes, and especially if it occurs alongside psychological symptoms, new onset psychological symptoms. Um, and dark reddish urine is also suggestive of it. But if we don't have that kind of urine, it doesn't mean that this patient doesn't have porphyria. Okay. And the screening test that is used to measure the levels of porphyria in the urine is very essential to confirm a diagnosis of acute intermittent porphyria. And the treatment of it is basically, since it's an overproduction of endogenous heme, you try and give heme to stop the body producing it. So you give an IV infusion of heme, and if IV heme is not available, then you can load the body with carbohydrates either through a diet or through IV dextrose. That can help. And the last thing I wanted to mention about porphyria is that only 10% of patients with acute intermittent porphyria will have recurrent attacks without a clear precipitating event. So, patient education regarding the avoidance of triggers is very important to improve long term outcomes. It's basically like an asthmatic. You just try and educate them on the things that they notice can trigger the attacks. Okay. Are there any
Yes.
suggestions, additions, questions for today's case? Any part of it?
Doctor, I have a question.
Yeah, go ahead.
Why did he have periumbilical pain?
So, the periumbilical pain is usually the site where porphyria occurs, but it doesn't necessarily have to be in that area. Any generalized abdominal pain, or any abdominal pain really, can be a porphyria.
And I have another question too, if you don't
Yeah,
mind.
sure.
Um,
Sure.
Earlier we said that small bowel obstruction could be fatal.
Mhm.
Uh, why is it fatal? I thought it was treated conservatively and was fine.
So it's it can be treated conservatively, you're right, but it's fatal in the elderly population mainly. Like I'm not exactly sure why it is, but statistically, in older patients, it's something to worry about when they have obstruction. I'm just guessing at this point because I'm not really sure myself, but I'm guessing because they have degenerative changes in their um, bowels, neurological wiring, that they don't really feel it, and then the gut just slowly dies away and they don't know about it. So it can cause a massive ischemia, and that's why I think it's more dangerous in the elderly population.
Okay, thank you, doctor.
All right, any other question?
No, thank you.
Okay, thank you all for this comprehensive discussion and very interesting case. I just wanted to point out that one of our audience members pointed out that bowel obstructions can lead to perforation and complete obstruction, and that's why it might be fatal. With that, let's just give the chance for our audience to share their comments and questions in the chat box.
I see a
Okay, so
question in the
yeah,
chat.
yeah,
How
Mika is
common
asking.
is this condition in the UAE? Honestly, I'm not sure. But generally worldwide, it's not a very common condition. If anything, it's quite rare worldwide. But the UAE specifically, I'm not very sure, honestly. I've only seen one case um, in my own like daily life so far.
Okay, any more questions?
No, thank you, doctor.
Okay, so if there are no more questions, I just want to remind our audience that they can always share the questions with us through our social media accounts, and we'll make sure to share them with both Dr. Fahad and Dr. Sarah. With that, we will conclude today's episode. I'd like to thank Dr. Fahad, who unfortunately had to leave us earlier, and of course Dr. Sarah, who ran this excellent episode. And a special thank you to Khadija and Yumna. You two were amazing, and it was a pleasure having you all with us today. We hope we meet you all in the future in another episode. Thank you and have a nice day.
Inshallah. Thank
Thank you so
you.
much.
Thank you so much.